Hello and welcome everyone. For those of you who have just joined, my name is Heather and I'm going to be the moderator for today's webinar. We are excited to present to you our webinar on reducing claim denials while increasing cash flow today. This is our first webinar in the Practice Improvement webinar series, so please be on the lookout for future offerings. Before we get started, I do have a few housekeeping items to go over. If you have questions for us, you can ask them throughout the presentation using the Q&A feature or the chat feature on the bottom of your screen. Those can be submitted throughout the presentation and we will address them at the end of the presentation during a Q&A session. We're also going to have a few questions for you that will be addressed using polls. There's going to be a small set of polls to be conducted before the presentation, and we do encourage you to participate in them. Before introducing you to John McDonough, I'm going to go ahead and launch that first set of poll questions. Our first question for you is about how you feel claim denials impact your cash flow. That's on the screen now, and if everyone would just please take a moment to answer for us, we would appreciate it. Thank you for taking the time to answer those. It looks like we have a three-way tie for those who answered between eligibility, authorizations, and coding being the top three denials that impact your practice cash flow. I'm going to go ahead and launch the second poll question. And this question is on your insight into claim denials. Thank you everyone for taking the time to answer our pre-webinar poll questions. It looks like 100% of our respondents have said that they feel they have good insight into their denials. So hopefully we can give you some tools to help you further with that. At this time, I'm going to introduce John McDonough. John is the Chief Operations Officer and was a member of Health Prime's executive founding team in 2004. For the past 17 years, John has provided leadership for more than 700 staff members and drives our core healthcare practice optimization operations. Prior to Health Prime, John served in senior and executive leadership roles in a variety of companies, including Tenet Healthcare Physician Services, Triad Hospital Corporation, and HCA Physician Services. He has over 30 years of diverse experience across the healthcare industry. John is a subject matter expert in revenue cycle management, and I'm sure you will learn something of value from him today. Now, without further ado, I'm going to go ahead and turn it over to John for the presentation.
Good afternoon, everybody. This is John McDonough. I'm going to go ahead and share my screen here. You should see my presentation coming up here in just a second. I'll go ahead and get it up in presentation view here for you. 1 second. There we go. So I'm going to be talking to you today about improving your cash by reducing your denials. And just a little bit about myself. As Heather mentioned, I've been working as the COO for Health Prime for over 15 years. Prior to that, I have an additional 17 years working in physician practices, initially as a practice administrator or manager, and then also as a chief operating officer for a very large multi-specialty group in Maryland. Spent many years working with HCA Physician Services, managing employed physician groups for them, as well as for Tenet. But most of my time was actually spent working in independent physician practice management. So I've got a good understanding of what it takes to operate a physician practice day in and day out, what you folks are going through, whether you're providers or office managers or participate in the billing side. So well-rounded experience that hopefully I bring to the table for our discussion today. So we're going to talk about some strategies for denial prevention and talk a little bit about what's causing denials and most importantly, as I said, what we can do to avoid them going forward. When we talk about business intelligence at Health Prime, typically when you talk about dashboards and KPI, key performance indicators, a lot of systems can provide you with data, the KPI that tell you how we're doing. And that's good. I mean, it's helpful, certainly, but we don't feel it's enough if you really want to truly understand and have a good sense of where your business is. We feel that on top of that, we need to layer on predictive modeling to answer the question, where are we headed? It's not just enough to know where we're at, but are we heading in the right direction? Those indicators that we hope are improving, are they? Those indicators that we hope or that we expect to grow, are they growing? But beyond that, we want to be able to understand the story. So looking at data from a snapshot can be a little frustrating, because if you see an indicator's moving in the wrong direction, my denials have gone up. They've gone up for what reason? You can maybe understand it a little bit by looking at dashboards. Well, maybe my coding denials have gone up, but it's really hard to understand where the story is unless you go back to the practice management system and then run some reports and then drill into those reports. If you're lucky, you've got a system where you can export that maybe into Excel or some other tool to try and drill into it. But our business intelligence, as you'll see, goes way beyond any of that, because we believe that it's not enough just to know how we're doing and where we're headed, but why are we there? What's the story behind that? And probably most importantly is, what can I do about it? Is there an action I can take? If I want to reduce denials and improve tasks, what's the most effective things that I can do? So we layer on decision support as a component of our business intelligence. And you're going to see all of this illustrated as we go through the webinar. The workflow, staying ahead of the curve, means that we start with patient intake and provider documentation. Typically, in any revenue cycle model, this is the responsibility of the practice to make sure we've got accurate demographics, we've attached the right insurance, we've got all the correct insurance details. If we need an author or referral, we've got the author referral. So this is a key part, and as you see, a lot of the fails related to denials are coming in from this point of service. Beyond that, we have pre-bill edits and audits, and this is something we pay very close attention to, because if we're given data, whether it's coding data, modifier data, diagnosis data that would be necessary to support medical necessity, we want to make sure that we can filter on those problems that would cause a claim to deny. So as we get ready to bill the claim, we go to CCI edits. We have other claim edits we've layered on top of it to give us the highest confidence that when that claim goes out, it's going to be clean, it's got all the information we need, and we're going to be able to reduce the denials. And then beyond that, the analytics, right? Being able to track those denials, report on them, understand them, and that's a shared responsibility. As we compile the data, we review it with our partners to talk about where we can make some improvements, or where maybe some improvements could be made at the front end, where are we going to get the biggest bang for the buck, if you would. And all of that should help us reduce denials and increase cash. So most medical denials are avoidable. Now, having said that, insurance companies don't make it easy to avoid them. Just as you understand a certain process and how to do it correctly for that payer, they change the rules up, right? So they never want us to be totally on the same page with them. The more they can deny, the less they have to pay. If you don't have an effective process for either reducing those denials ahead of the curve or working them very strongly after they've denied, the insurance companies are going to win. You'll provide services that ultimately do not generate payment, and they're able to keep those payments that should be paid to you rightfully. What we know is that in best practices, we're going to find, and we're going to see this in the lower part of our table down here in the bottom right, the best practices are going to have under 2% typically in denials, or at least controllable denials. That's as a percentage of charges. Better performing are going to be in the neighborhood of 3 to 4%. Here we've got actual data coming in from some practices where we're actually showing our results 1.4, 2.9 in the better performing. And then typical practices are going to be more in the 5 to 10% range, with many practices actually above 15 and even as high as 20%. So depends on the issues you face related to your particular payers. And it depends on how strong the relationship between where the service is provided in the office at the point of service, or it could be at the hospital or the nursing home, and the billers who are responsible for getting that claim out cleanly. It's important to know that rework costs about $25 per claim. And it's not just on the billing company, right? Because a lot of times the rework has to go back to the office. You have to have extra time invested by your provider to provide a new diagnosis, more specific diagnosis, or to approve a modifier. Billing staff time in the office that has to be utilized to handle tasks that can't be performed by the revenue cycle partner. And certainly we have costs on our side as a revenue cycle partner in getting those claims reprocessed out the door with the corrected claim. So again, depending upon how strong your processes are and how strong that relationship is with your billing partner, a typical provider practice could see anywhere from 5 to 25,000 per year per provider actually written off or adjusted off because of denials that should have been collected. So we're going to get into a little bit more on that in the coming slides here. First steps in denials is prevention. So it's fine if you're able to work denials as they come in, but ideally what you want to do is you want to improve what we call your first pass payment rate, or reduce the number of denials, get your first pass claims paid up over 98%, and you have the best opportunity to impact your cash in a very positive way. So number one, we need to understand what the root cause is. What's causing the denials? Here we've spoken a little bit, patient access and registrations, making sure that the demographics and insurance information is collected properly. As many of you know, hopefully all of you, but maybe not, just misspelling the patient's name, first name, last name, could be enough to cause a denial. You have everything else right, the insurance information is right, but the name is misspelled. That could cause a denial because you'll see a mismatch coming from the payer, either at the point of eligibility checks, or if it passes the eligibility check at the point of claim adjudication, you'll get that coming back. Pre-certification and plan benefits, also very important. Pre-cert would be making sure you've got necessary referrals and authorizations. I think that was one of the things that was mentioned by the group here on the call today, as for at least their particular practices, some leading root causes for denials in their group, making sure that if we're going to provide an echo for a payer that requires an authorization for an echo, that before we perform that service and bill for that service, we've actually got the authorization and we're able to provide that service and get it paid. Coding billing errors, another one that was mentioned on the survey at the beginning of the webinar. This involves a lot of work with providers, just making sure they understand how to put the proper diagnoses in that are going to support medical necessity. If they need modifiers, to be able to teach them the key modifiers that might be important for them to help the billers with. Documentation deficiencies, there's a lot of uncontrollable denials because the payer just simply asks for documentation. They want to see a copy of the medical record. So the medical record not only needs to reflect the fact that the provider did the service. That's not necessarily what the payer is looking for. They assume you did the service because you billed for it. So they're not just asking you to prove it, but your documentation should show you did it, exactly what you did, and why you did it. Because if there's no clear indication in your documentation as to the reason you're doing this, what is the medical necessity for this particular diagnostic or procedure, then chances are they're going to pay it as not medically necessary upon review of the documentation, or they could down code it if they want in terms of an E&M code. So having the right documentation for those times when you can't control the denial, the payer's just requesting the documentation, making sure that documentation is going to support what you did and why you did. And then payer behavior. You could do everything right, but regardless, you're going to see a small percentage of denials, and not really small, maybe 1% or so, coming in just because the payers have denied an error. They'll deny something for an auth that doesn't require an auth. They'll deny a service for a doctor saying the provider's not credentialed and the provider is credentialed. All right. So you could do everything right, but the payer themselves are making the mistakes. And you have to have a strong team of people on the backside understanding that when it's a payer error, we recognize that and that we get that claim processed immediately and correctly, so that we don't have to tag the office with unnecessary work on a denial that should not have been processed as a denial in the first place. So determining the root cause, very key if we're going to try and prevent denials going forward. And then from that, prioritizing the playbook. So we know what's happening, but why? Is there a particular provider or location or a service line or a payer or a code or a process that's causing the denials? Let's focus on those that give us the biggest bang for the buck, if you would. Those that if I could solve for this 1 or 2 problems, I might be able to prevent 50, 60, 70% of my denials. So we'll be showing you throughout this webinar how we do both of these, working with our analytics processes and our business intelligence. So in looking at the pie here of where denials are coming in, they span the entire revenue cycle, although a large percentage are associated with front-end processes. So you see those that are outlined in the dark black: authorizations, billing issues, credentialing, eligibility, plan benefits. Altogether, probably half of all denials are coming in from those parts of the revenue cycle that have to do with pre-registration and patient intake, as we've already mentioned. So a big chunk of these are having to do with, are we getting it right when we register the patient and when we check them in? Because if there's a fail there, there's a chance there's going to be a denial or at least additional work coming down the road. Beyond that, the coders involved. So we've got maybe 15% of denials coming in for medical necessity, generally associated with maybe a diagnosis that's not supporting the code selected, or a coding issue itself. It's the wrong code. It needs a modifier. The modifier is not there. So a good chunk of those denials coming in from provider responsibilities, where we can work with providers and teach them how to do certain things to make sure they're not coding unspecific diagnoses. For example, if they're coding for services that require a NCD or LCD specific diagnosis, that we provide the coder with those diagnosis lists so they know exactly what to choose from for that particular service that was rendered. And then a large percentage coming in as duplicates. This is a fail on the back end side when a claim goes out that either shouldn't go out a second time, but it went out anyway, or maybe it should have gone out as a corrected claim and it wasn't tagged across properly, and it wasn't processed as a corrected claim. Instead, it was processed as a duplicate. And here's another place where we see payer error, where we've done everything we can to process it correctly as a corrected claim, and yet they deny it as a duplicate. And now we have to call the payer rep, make sure it gets reprocessed, be able to show them how that claim was tagged as a corrected claim. And then some shared responsibilities here. Timely filing, which is a big chunk, over 6% in our database. And our database is actually our Datalytics platform, where we've aggregated data from over 600, nearly 700 practices, over 1,500 providers, and over 1.7 billion in charges processed in the past 12 months. So a lot of data we're looking at, about 6% of that coming in from timely filing. That I shared because that could be a problem with the provider not submitting charges on time, hospital charges or nursing home charges or anything outside the facility, most typically causing a denial because it was too late. The front desk was holding up some fee slips, or something got lost, stuffed in a drawer, didn't get scanned, didn't get sent, and we find them weeks or months later, send them in, and it's too late. Or it could be on the back end side, right? The charges were presented to the billers, and for some reason the billers didn't get those processed or didn't get them processed in time, and there was a fail there. But a lot of these are actually biller errors. It's probably the number one reason for biller error is timely filing, where they'll deny it for timely filing, and yet you've got proof it was filed on time, and you have to get that claim submitted or reconsidered with proof of timely filing. A lot of hassle for that, but that's one of the ways payers can win, is if your team's not on top of that, right? If you just assume, oh, it's a timely filing issue, I'm going to write it, then you'll be writing off a lot of errors related to payers who are denying when they shouldn't be. So something to watch very closely there, as every part of the spectrum for revenue cycle is touched to some degree by timely filing. We talked about a couple causes which really are not that controllable. One is coordination of benefits. As you know, this is when the payers put a hold on the claim. It's not really a denial, it's a delay, but they tell us that they're not going to process this claim until they've received some information back from the patient, just so that they can verify if they're truly responsible for that claim or not. Could be on an accident where they're concerned maybe there's a third party liability insurance that might be liable for that, an auto insurance, a homeowner's insurance. Could be maybe something that they're concerned happened at work and could be covered by work comp instead of the medical payer. Or it could just be a scenario where they know the patient's covered by at least 2 insurances, and they want to make sure that they've got it properly tagged to who's primary and who's secondary. So they send a questionnaire to the patient to answer, put a delay on the claim. We can't really control that. We can make sure that these get processed and paid eventually, but we can't control the fact that it was denied or it was delayed for coordination of benefits. And the big part here of the denial pieces, and over here you see a little thermometer, about 46% of the denials we see are coming in for non-controllable reasons, so just under half. And of that, 2/3 for requests for documentation. We already discussed that. And the other third for coordination of benefits issues. The other 53% are coming in for what we consider to be controllable reasons. And even some of the controllable denials are really not controllable to the extent that the payer is denying them an error. We can't control the fact that they're making an error, and we have to resolve for it. So they'll come in as a controllable denial, i.e. timely filing. Turns out they shouldn't have denied it, and we have to get it reconsidered and reprocessed. So here are the most common denials for controllable, and we showed that earlier, but this is just specifically focusing on those that we feel have some degree of control over them. Authorizations, about 9%. Billing issues, these are typically related to demographics, but they could be related to other things, such as the claim forms not properly filled out. As you know, if you're involved in billing, every payer has a specific way they want that claim to be populated. And if your software isn't populating it properly, it'll cause the claim to kick out because they're looking for some information in a box and that information is not there. Coding denials, credentialing denials, eligibility denials, that's another one I think you folks had put on as maybe one of the top reasons, and we're seeing that that is true. And this is denied after the clearinghouse, right? So the clearinghouse has already rejected claims that they can find that the patient is not eligible for, and those that they cannot find, they'll pass on to the payer. Then the payer rejects these. Almost 20% of the controllable denials that we're seeing are related to eligibility that passed the clearinghouse and then got hung up with the provider, and a lot of those associated with marketplace plans, the Obamacare plans, where it's the patients themselves who pay for their premium. So the payer may think that the patient is current on eligibility through the end of July, only to find out they never paid for the July premium, which means now they have to deny all July services for eligibility, even though maybe on July 10th, when the patient came in, they showed that patient is eligible. So a lot of that issue associated with those plans. Medical necessity, we've spoken about. Plan benefits, another big one, depending upon the type of practice you have. This could be everything from, how many, for example, a Medicare patient is allowed an annual wellness visit. We'll know that by now, hopefully. But they're not allowed to have more than one in any 12-month window of time. So your processes have to be clean enough at the front end and our edits good enough on the back end to be able to identify, as this patient already had an annual wellness visit in the last 365 days. If the answer is yes, that's not a service we can bill Medicare for. It'll be denied as a plan, a benefit problem. And unless you have an ABN, an advanced beneficiary notice on file, you're not going to be able to get that patient liable for paying that claim either, and you'll have to write it off. Other plan benefits as well, depending upon your practice, is a big chunk. So this is what we focus on when we work with our clients, are this wheel here. How can we make improvements in here? What are the root causes? And then what's the playbook or the plan to start solving for these? So at pre-registration, what we can do is help with your staff, educating you where those fails might be. Do you have a particular office, a particular location, a particular person who's checking in where we might see these fails more often? Verifying insurance eligibility and benefits, whether that's done in batch mode or whether that's done at the point of service. Insurance plan changes, making sure we are running real-time eligibility, especially when the patient has told us they've changed insurance. It's not enough just to get their insurance card and the new information. We need to do an on-demand eligibility check on that right away at the point of service. Especially if there's been any coverage change within the plan years. And it's a good idea just to verify insurance with patients every time you see them. Only because even with Medicare and Medicaid, patients can switch from traditional Medicare to a Medicare Advantage program, or they could switch from one to another. They went from the Aetna plan this year to the United plan, and you want to make sure you're staying on top of that. The MCO plans through Medicaid, patients can move even quicker in our experience, depending on the state. Also scheduling, making sure that as we schedule, we're validating insurance so we can do the batch eligibility checks prior to the appointment date. And that we know the service they're requesting, and we know based on the insurance whether or not we should have an auth number, and that we let the patient know we require an authorization, and maybe make sure that we contact the primary or the referring doctor to get that auth number if the patient doesn't have it. And then an authorization team to verify those authorization requirements, correct the authorization. It's a good idea to record those calls when you do get an authorization, or at least capture an image if you process it online. So you've got some backup. If there is a problem with the auth, you can prove that you got it. That's helpful once in a while. Generally, the auth process works, but not always. The key here is making sure you've attached the correct auth to that particular service. You might have an authorization on file, but it's for Dr. Smith providing, a cardiology consult, and you've attached the one for Dr. Johnson providing a GI consult. So making sure that the authorization is in effect, that the number of visits hasn't been fully used already, and you've got an actual authorization that is payable. Back office edits and audits. Like I said, this spans the revenue cycle. So there's things that we can do or your billing can do to work with you on making sure that insurance cards and demographics are validated and they match the practice management details. So if you're scanning in a copy of the insurance card into the chart and you've chosen that as the active insurance because the patient has verified that, then we want to be able to make sure that we can validate it, the name spelled correctly, and it's, the provider number or the patient ID number is entered correctly, the patient group number is in there correctly. And we can also assist clients. It's an add-on to our services, but we do have clients where we assist them with the bulk eligibility, where we can run that a couple days before the appointment and then send the front desk the list of patients who fail eligibility so that you can contact those patients prior to visit to get the proper insurance or at least tag them so that when they show up at the front desk, or you remember to ask them for their insurance information. Also, we talked about various edits that should be in place with a sophisticated billing partner, the CCI edits, practice-specific audits as well, relative to nurse practitioners and new patients, for example. CCI isn't necessarily going to catch all of those types of things that you have to have additional audits for. Medical necessity, NCD, LCD, LMRP, sophisticated systems will include those in their real-time edits, but not all do, in which case we have to have manual edits for that or audits before those claims are submitted to make sure if we've done an echocardiogram and there's a list of maybe 30 diagnoses that Medicare pays for, that the diagnosis selected is on that list and we're not going to bill it and get a medical necessity denial because it's not matching the LCD for that. And that we've configured the claim library properly so that we avoid some of those issues with billing denials when the claim isn't populating properly. It happens a lot with secondaries because different secondaries require different information on the claim when you submit it, even though it's going electronically. But it's also the case on primaries where in a certain box, one primary insurance is looking for an NPI number, another one might want a tax ID number. And you have to make sure that your claim is populating correctly for all the boxes related to the claim rule set for each payer. And then authorization support. So we've done this in the past as well. We can actually open the auth, verify that the auth that is attached to that claim is accurate, that it's not expired either by time or by number of visits, that it is correctly attached to the service that's being provided. And if there's any issues with that auth number that was attached, get back to the practice right away and let them know we have a problem with the auth, as opposed to sending it off, waiting for it to be denied, and then coming back to the practice maybe 2, 3, 4 weeks later when we have an EOB or ERA, and then letting them know the process held because it might be too late to request a new auth or retroactive auth at that point. So the one place that's the most difficult for us to give help with is plan benefits, but there is some things that we can key in for you on that as well. And so as we take a look at the profile coming in for individual and specific denials, we look at, is there a playbook that we can assist with plan benefits denials as well, especially in practices where we see that that might be a significant component. So the top 6 reasons for denials, just kind of recapping what we've gone through: missing information, leaving just one field blank is a significant issue. Inaccurate information. So you've got the information there, but it's wrong. It's either populated wrong on the claim form or it's just entered incorrectly. The service has already been adjudicated. That could be a duplicate, or it could be a coding issue where there's some unbundling going on, and without a proper modifier, you're asking for payment on a service that's included in another service. And then after that, it's not covered by the payer. So that's a plan benefits issue. Again, that goes back to the illustration of the annual wellness visits for Medicare. More than one in a 365-day period is not covered. I know in Georgia, for example, Medicaid only covers 10 visits, physician visits a year. So as you get further on in the year, if you know you've already had 10 visits, you know that the next one's not going to be covered. Sometimes you don't know simply because the patient could have gone into a walk-in clinic or seen another doctor that you're not even aware of. And those visits go against the 10 visit maximum for Medicaid patients. So we see those kinds of issues as well for the non-covered by payer problems. The limit for filing is expired. We spoke about that a bit earlier. A lot of different root causes for that. Could be the provider, could be the front desk, could be the back office, could be the payer denying those in error. So really need to understand what the root cause is there and then solve for that with the appropriate playbook. And then prior authorizations and medical necessity. We've spoken a lot about these again, but these are the six biggest issues. And those are all included on the ones that you guys spoke about at the very beginning. Eligibility being missing information or inaccurate information. So now we're going to talk about how we work with our clients and the kinds of business intelligence we're able to gather to help with the reduction in denials, help moving it from 10% to 2%, if that's where you're at and where we need to get you to be. So what we've got, and I'm going to just show you briefly, is our Datalytics tool, which for all of our clients, at least depending on the software, this isn't available for all softwares, but this is available for our clients on NextGen, Fire, Cario, and GEMS right now. We've got a client on ECW that's in this as well. This is the online portal for our demographic, for our Datalytics, and we could work ourselves through this, looking at all the various KPI, focusing on denials and how we are able to support the processes practice we see has about 1.5% of charges coming in with denial issues. That compares to 1.6% a year ago. But rather than walk you through this, I've actually just taken screenshots. So I'm going to go back to, oops, I'm sorry, I didn't mean to do that. I thought I could go back to where I dropped off. So I'm just going to walk you through the screenshots and really focus on those parts of the Datalytics screens that help us get to understanding denials and putting together a playbook to resolve them. So first we look at the clearinghouse acceptance. Not all denials come directly from the payer. Some happen at the point of the clearinghouse. We like to see about 98 to 99% of claims passing the clearinghouse. And here we're seeing almost 100%. And of those that do deny, the number one issue is eligibility, as suspected. There's also some demographic issues on the claim that cause things to deny, or printing issues on the claim print library. Beyond that, once it gets from the clearinghouse to the payer, we like to see a 98% first pass claims paid. Now, to be honest with you, this is where we see numbers anywhere from 80 to 98, right? Best practice is up around 98 or better. Better performing down maybe 96 to 98, 99, and then going down from there. If it's under 90 especially, we feel there's a lot of opportunity for improvement, but we're never happy even when it's 97.5. We want to see, can we resolve for whatever controllable denials are coming in to make it even better. We're just never satisfied with the number as is, even if it's showing it's in better or best practices. So from here, we can move on to a history of our first pass claims paid rate. We see that it's been averaging 97.5 over the past 10 months. However, it's been over 98%, fairly often, and it's only been fairly recently where it's taken a nosedive. So we really want to focus on what's been happening the last couple of months to see what changes have happened or what's occurring now that we have to solve for. Because again, even when you have things working well, they can go out of control real easy. The payers changed the rule, you didn't catch it, and now you're seeing denials that you hadn't before. There's a new person at the front desk there's a new provider, we've got a new person on the billing team. Could be a lot of things that cause really well running processes to start failing. And so we want to be on top of this right away. So we're just looking at the calendar year 2020. We're looking at down here in red, controllable denials. If you remember from that thermometer I showed you earlier on the presentation, we're looking only at controllables. And we're seeing controllable denials are about 1.1% of the total denials. So, you know, we're at just over 2% total denials and about 1.1% of that coming from controllable reasons. Although there's a lot that happened here in June. And then we're seeing those denials that are a part of the controllable process, a lot of things related to billing issues, demographic issues, errors, a lot related to eligibility that has passed the claim, the clearinghouse, but has failed at the payer level. Some authorization issues as well on this particular account, a little bit with credentialing and a little bit of timely filing as well. So we want to solve for all of these and figure out what are the issues. So next we go to, we're able to drill down. If you recall from the very beginning, we want to know the story. We want to, without having to run reports at the front end, understand what's happening here. So the number one issue for denials is billing. And I want to constrain this to just the last 2 months. So I'm going to change this and look at just the last 2 months because that's where we saw kind of an uptick in our timely filing, and we want to make sure we're seeing. So the number one issue, the single number one issue is related to pre-certs and authorizations, followed by billing issue, claim lacks information, incomplete claim. Is that a print library issue, or is that something that was missed on demographics capture? We have to solve for all of that with the corrected claim that has the information the payer is looking for. So this gives us a nice view, but you see this table here is a little difficult to work from here. So we actually have the ability to export this to Excel. And in Excel now, you've got all of the denials, and you can put them into a pivot table in Excel, or we can do that for you. And that's going to then give us the ability to produce a PDF version to provide you that says, okay, the number one issue for denials in the past 2 months, there's been 3 auth issues. That's been about a third of denials coming from Cigna Priority Partners and the VA. And here are the services that were provided that caused those denials. There's a benefits max from a Cigna plan, a pre-cert missing from Priority Partners, which is an MCO, and a pre-cert missing from a VA CommCare network. So again, let's put some processes in place to make sure if we're going to provide these services for these payers, that we have a process in place to make sure that we have an auth number, and that auth number is attached to the claim before the claim actually heads out the door. Beyond that, some eligibility coming from Med Plus, United Healthcare. So showing you exactly where we're having the issues, which providers we're having those issues on. And if you'd like, if there's multiple locations in a practice, we can tell you which locations is having the most issues with eligibility. So again, our playbook, which was, if you recall, understanding the root cause, authorizations, eligibility, billing, and then working them down in such a way that we're handling those that cause the biggest problem. We're dealing with those first, solving for those, and then we continue to work ourselves down the list. But then the list next month might be a little different. So in order to solve for that, we have another tool, which I'm not showing you right now, but that's available for all of our ops consultants, and that we've just deployed in the past couple months to our practices as well, is our weekly operations report. And on that, we're looking at the denials that came in last week. So we're not even looking at things that are a month old. We're looking at things that are just a week old and working to solve for those denials every week as we see what's popping up as the new reason for the denial coming in. And this is that report here. So you could see that for the week ending 7/18, when I took this snapshot, this is a different practice. This was about 2.72% of charges that come in, but there had been a lot of work with this practice, which was new at the time. And we were seeing back in May, 14, 10, 14, 18% of charges were being denied. We worked that down to better practices, down in the 3 to 4%. And we're working our way towards best practices here, trying to hopefully get this under 2% and keep it under 2%. And again, here, the number one issue for this particular week was related to credentialing. They may or may not have been denied in error. All right. After that, some coding issues. We can click on the coding bar here, understand exactly what those coding problems were, make sure that, for example, this code is inconsistent with the modifier used to require what combination of code and modifier generate that or edit in place so that we don't do that again, or that we can educate the provider if it's a provider is the one that needs to attach that. So we just work ourselves down according to what we showed at the very beginning. What's the root cause? Where are the denials originating and why? And what has the greatest impact? And any practice, whether they're a provider of one of our practices where we've got their data on Datalytics and we can look at their data on our business intelligence through the weekly operations report or our monthly operations report, we're the partner to help you solve for those. I'm anxious for you guys to talk to your ops consultants about strategies you might want to deploy to start improving denials on your end. You know, this tool is available for any software where we're able to get an access to the back end and stuff from our carrier clients. Like I said, we've got this up and running on our other clients as well. If you don't have access to this, there's other things we work with our clients on, other tools that may be a bit more cumbersome than this, but it's still the same playbook. What's denying and why? We might have to do a lot more front-end reports, do a lot more analysis in Excel. It's so easy to get to the story, but we can get there. What's denying and why? And then where can we make the biggest impact as quickly as possible to start making improvements on that? And that's the end of my presentation. So hopefully you've learned a few things, and we've left enough time now for questions. And Heather, I'm going to stop sharing. I'm going to turn this back over to you. And if anybody's had an opportunity to put some questions in chat while I've been talking, great. Heather will go through those and I'll answer any to the best of my ability.
Yes, thank you, John. Before I go into the Q&A, I would like to just ask one poll question for everyone who is on the call. If you would just take a moment and let us know if you felt that this webinar was a valuable use of your time, we would greatly appreciate that. Wonderful. Thank you, everyone, for taking the time to answer that poll for us. We are very pleased to hear that we've not wasted your time today. To go into the Q&A, what came in during the webinar, John? We'd like to know, does a denial mean that you will never get paid?
Great question. No. A denial means that we have to rework it, and that rework can be expensive both for the practice and for the billing side. But we're able to get probably 70 to 80% of denials paid with a corrected claim or with the information that the payer has requested in order to completely process that claim. So no, it doesn't mean because you have the denial that you're going to get paid, but it does slow down your cash. And so it's a tool that payers use. Their objective, if you think about it, is to not pay you. I mean, wow, what if everybody went to work and their employer's objective was to not pay them for doing work? You know, that's what physicians have to deal with. The objective of the people who control your income is to not pay you, and they think of a lot of ways that they can do that, whether it's barriers to billing, whether it's denying claims they shouldn't deny, or having your staff jump through so many hoops that in order to get something paid, there's likely to be some mistake along the way, the provider mistake, the front desk mistake, the office mistake, and fingers crossed for them, we don't process that correctly, we don't get a corrected claim out, we don't get the information they've requested, and they never have to pay it. So it's a constant battle to make sure that those denials actually don't result in write-offs. But the other thing we do on our analytics piece is we track all adjustments the same way. So if we've had to adjust money off for timely filing because we could not get it paid, then we'll know that. If we had to adjust off money for credentialing because the provider saw a patient prior to the credentialing being effective, we know that. We could track those adjustments, trend those adjustments as well. Same thing with coding issues and on and on. So yes, those times when we actually do have to write something off because it cannot be paid, it does happen, but it's not nearly all. In fact, it's less than 0.5% of the time, to be honest. So the biggest issues with denials are reducing or expanding the amount of time it takes for you to get your cash, slowing down your cash, your cash stream, and then also the costs that are involved in reworking those claims from the physician to the front desk, to the medical assistants who have to gather information, and to the back office who has to rework those claims as well.
Thank you, John. The next question is, how and when are we notified of denials that require our intervention?
All right, so our standard process, and we have different processes based on the way we work with individual clients, but typically we have a tasking module, and where we have claims or denials that are specific, where we need the help of the practice, either the provider, some attention, some information from the provider to clear up a denial, or something coming back from the front desk or the billing coordinator. We generally handle that through a tasking system. And our standard is when the denial comes, we'd like to get that to you guys within 24 to 48 hours so that we've got plenty of time to reprocess that denial and get it paid.
All right, thank you, John. It seems that those are all of the questions that came in. For any of you on the call, if you do think of something after this, definitely reach out to your operations consultant, or feel free to email me, Heather Abrams. You'll have my email from the invitation. I thank everyone for their time today, and I hope you enjoy the rest of your afternoon. Thank you.
Thanks, everyone.